So at the outset, I would like to thank AstraZeneca for giving me an opportunity to present the real world data. So in this meeting, we have two medical oncologists from Shimoga. I would like to welcome them first and foremost, Dr. Aparna and Dr. Namrata. They are from my native place, and I'm very happy to participate along with them. So coming to introduction, in patients with EGFR mutation, progression-free survival improves after the treatment of EGFR TK as compared to that with cytotoxic chemotherapy. This was old data. Then osimertinib, as an irreversible third-generation EGFR TK, demonstrated a clinically meaningful improvement in median progression-free survival, 18.9 months versus 10.2 months, more than 8 months benefit. In a phase 3 randomized control trial, that is FLORA trial. I will probably quickly go through this trial. And even overall survival was also pretty good. It was 38.6 months versus 31.8 months with the p-value of 0.045. Again, going in favor of osimertinib. So quickly, I'll just go through the FLORA trial. This was in patients with locally advanced or metastatic non-small cell lung cancer. Key inclusion criteria were patients more than 18 years, WHO performance case 0 to 1. Two specific mutations were included in this study, that is exon 19 deletion and L858R. No prior systemic chemotherapy with EGFR systemic chemotherapy or with the EGFR TKI therapy, and stable CNS metastasis were allowed here. And stratification was based on the mutation status, exon 19 deletion versus L858R. And also it was also based on race, Asians versus non-Asians. So osimertinib was given at a dose of 80 mg per day till the patient had progression, and the competitor was geftinib or erlotinib at the standard dose. And the progression-free survival was the main endpoint. So this was a very important study because here the comparator arm was not chemotherapy arm. It was a standard of care at that moment of time. That was either that is geftinib or erlotinib, and it was compared with osimertinib. And if osimertinib proves increased progression-free survival or overall survival benefit against geftinib or erlotinib in EGFR mutated patients, definitely it becomes the standard of care after this trial. So in this, if you see the baseline characteristics, interesting thing is Asians. Most of the patients were Asians. Predominantly female populations were included. And also, if we see the adenocarcinoma, majority of adenocarcinoma, exon 19 deletion was more. It was around 63% versus 37% of L858R. So progression-free survival was pretty impressive with the hazard ratio of 0.46. It was 18.9 months versus 10.2 months, and it actually gave, if you see the forest plot, almost all the subset actually had benefited with the osimertinib compared to first generation TKIs. If you see the overall survival survival curve also, osimertinib had the overall survival was 38.6 months versus 31.8 months with the comparative EGFR. And the conclusion of FLORA study showed that a statistically significant and clinically meaningful improvement in the overall survival with osimertinib. Median overall survival for the patients in osimertinib arm was extended by 6.8 months. Osimertinib in the is the first EGFR TKI monotherapy to show a statistically significant overall survival benefit versus another EGFR TKI. This is a very important statement. After 3 years, 28% of the patients in osimertinib arm and 9% of the patients in comparator arm remained on first line study treatment. Again, very, very impressive. Around 1/3 of the patient remained in the study in the osimertinib arm even after 3 years. Osimertinib presented a favorable and a consistent toxicity profile despite prolonged exposure. So the final overall survival in FLORA reinforces osimertinib as the standard of care for first line treatment of patients with EGFR mutated advanced non-small cell lung cancer. So again, if you come to NCCN guidelines, the EGFR mutation is discovered prior to the first line systemic chemotherapy. Preferred is osimertinib. And if the EGFR mutation is discovered during the first line chemotherapy, either you can interrupt and change over to osimertinib, or you can complete the planned systemic chemotherapy. Then during progression, you can change it over to osimertinib. So coming to the real world data, there are 3 studies which I'm going to speak on. I think I'll not go into the depth of the study. The slides which I thought are interesting, probably I will highlight on those studies. The first study is called flower study. Why exactly real world data is important? Because in the trial only 2 to 4% of the patients with the cancer will participate in the trial, and how effectively this can be this can probably I mean it can be practiced in the real world is very important. So how exactly the osimertinib has performed after it has come to the market is the effectiveness of osimertinib which was highlighted in the flora study. Is it being I mean, does it manifestation in the real world also is very important to basically know. So that's why real world data is very important, and real world data have become useful tools to assess unique insights in routine oncology practices and post marketing settings. So this flower study had around 126 subjects. Median age was around 68 years. Brain metastasis was present around in 30.2% of the patients. Majority of the patients were stage 4. In that, stage 4B was around 90 patients, accounted for 71.4%. And the inclusion criteria of the flower study included age more than 18 years, histologically and cytologically confirmed diagnosis of non-small cell lung cancer, presence of one or more epidermal growth factor receptor mutation. It did not have only exon 19 deletion or L858R. It also included other mutations which we come across. It was rare mutations were also included between exon 18 to 21. Locally advanced recurrent metastatic disease, stage 3B and 4 according to the 8th edition of TNM classifications were included. Eligible to receive first-line treatment with the 3rd generation EGFR TKI osimertinib were included. And patients who received the study drug in clinical trial were excluded. So the primary endpoint here is something called time for treatment discontinuation. So this was very important. I'll come to it why exactly it was important. Time for treatment discontinuation measured from osimertinib start to the discontinuation of the osimertinib due to any other cause. The other primary endpoint was rate of treatment related adverse effects, and the third important primary endpoint was rate of dose reduction and temporary or definitive treatment interruption due to adverse events. Just give me a moment. Yeah, sorry for that. Okay, so treatment for time for treatment discontinuation is very important, because in real world what we see is when the patient is on can you hear me?
Sir, audible, sir.
Yeah, so treatment time for treatment discontinuation is very important. It's a surrogate marker of PFS actually. Why exactly it is important? Because in real world, if there is a oligoproliferation, say there are some 5 to 6 sites of metastasis, and we start the patient on osimertinib, and if we think that there is one place where it has progressed and rest of the places where it has regressed, probably we will continue osimertinib. So we don't basically discontinue with the osimertinib or with the primary treatment, and we continue it. That is how the real world actually, I mean, we practice. Most of the patients, most of the physicians do practice. It is based on a clinical judgment. So time for treatment discontinuation is one of the very good indicators for real world data. Actually, based on around 12 to 14 meta-analysis, they concluded that TTD is a good modality to basically explore when it comes to real world data. So coming to secondary endpoints, the secondary endpoints was median overall survival, median progression-free survival, overall response rate, disease control rate. Also, there was diagnostic therapeutic pathway where actually during the progression, the patients were tried to there was an attempt to make rebiopsy, and there were attempts to make the find out the resistant mutations because of which there was progression. So coming to primary assessment and effectiveness, patients with the poor performance status, comorbidities, rare EGFR mutations, and active brain metastasis who are actually excluded in the FLORA study were included. This is how we treat the patients in real world. We treat the patients with poor PS comorbidities, rare EGFR mutations. So whenever these kind of patients come, we try to basically put the patients on osimertinib, or so these patients were included. Outcomes were similar to the published data, that adding to the consistency of osimertinib efficacy. I'll come to it little later. No difference in the PFS, time for treatment discontinuation, and overall survival noted in elderly patients, patients with comorbidities and less common EGFR mutations. So if you see the primary assessment, so the median time for treatment discontinuation was around 25.3 months. It was more than the PFS which was observed in the FLORA study. And if you see the patients with or without symptoms, two important categories where the patient, or two important subset where the osimertinib performed better is those patients without any symptoms at the diagnosis, and the patients with less than 3 metastatic sites. So these were the two places where the osimertinib actually did well. And the PF and the TTD was far better than the patients who had symptoms or who had more than three metastatic sites. So patients, as I told, so the patients with symptoms, and the patients with less than 3 metastatic sites, and the patients with brain metastasis, these were the patients who did not do well. And there was a significant difference in the when they did the multivariate analysis. So coming to how number of CRs, PRs, and stable disease, majority of the patients, there was no CRs. Majority of the patient had partial response. 73% had partial response, and around 23% had stable disease. So if you come to the progression-free survival, progression-free survival was far better in those patients without brain metastasis, and also those patients without any symptoms. So already spoken. So when the patients progressed, there was around 44 patients had progressive disease. 21 patients underwent biopsy at progression. Tissue biopsy was attempted in 44 patients, and liquid biopsy was attempted in in the rest of the patients. And there was, if you see the resistant mechanism for the for osimertinib, MET amplification, as we all know, was one of the very important factor for resistance to osimertinib. It was found in around 4 patients. MET and EGFR amplification in 1 patient, EGFR amplification in 1 patient, and HER2 amplification in 1 patient. Safety data, it was almost consistent with the FLORA data. But one thing which is, or two main things which came out of this real world data is, one is pneumonitis, which was far more in osimertinib group. This was, it accounted for around 9.5%. 12 patients had ILD or pneumonitis. And the second one is venous thromboembolism. Again, it was found in around 9.5% of the patients on osimertinib. So it was, there were few instances where osimertinib was associated with pulmonary embolism. This was not seen in this FLOWER study, and the more venous thromboembolism was more common. But this venous thromboembolism was not associated with age, performance status, comorbidities, and tumor load. So there was no difference in the survival outcome, which was observed according to the age, comorbidities, type of EGFR mutation, osimertinib's confirmed effectiveness, and the safety in the real world scenario. So this is one of the studies, that FLOWER study, which clearly showed that the effectiveness of osimertinib, the TTD was more than 21 months. And with this FLOWER study, what I could gather was, we have to look out for this pulmonary toxicity, pneumonitis, and venous thromboembolism, which is probably the two important things which was not highlighted in the FLORA study. So coming to the second real world data, it is called OCFACT study. So in this, inclusion criteria included advanced EGFR non-small cell lung cancer with osimertinib as initial treatment, Patient who exclusion criteria included patient concurrently using other anti-cancer agents or undergoing thoracic radiotherapy, undergoing post-operative adjuvant chemotherapy, receiving osimertinib as a second-line treatment. Baseline characteristics, you have to just remember that there was many patients with liver metastasis. Also, there were many patients with pleural and pericardial effusion. Here, one more important thing is they did analysis on PDL1 status also. PDL1 more than 50%, around 11.9 patients were there. 1 to 49 percent, around 31% were there, and less than 1%, around 30% of the patients were less than 1%. And the number of patients who are included in this OSIFACT study was around 538. It was much bigger than the FLOWER study. So PFS was the primary endpoint. Overall survival, TTF, response rate, safety, and post-treatment, CR, PR, and stable disease were also studied. Overall response rate and disease controls rate was other secondary endpoint. So if you see the PFS, it was around 20.5 months, was almost similar to the FLORA data. Male gender, malignant effusion, liver metastasis, and advanced unresectable cases. These were the patients actually who did not do well. So again, I'll repeat: male gender, malignant effusion, liver metastasis, and advanced unresectable cases did not do well. And again, the patients with who had a PDL1 score of more than 50%, the PFS was 11.1 months, compared to those patients who had less than 1%, the median PFS had not reached. So definitely the patients who were PDL1 positive did not do that well compared to those patients who did not have PDL1 positivity. So this is again same thing. The patients with pleural effusion, liver metastasis, advanced stage of the disease, and higher PDL1 subset did not do well, and male gender was associated with poor prognosis. Here again, in this OSIFACT, one of the side effects, why did the patients discontinue? The majority of the patients discontinued because of disease progression. Other important factor why the patient discontinues was pneumonitis. Around 25.6% had pneumonitis. So always remember, when you are using osimertinib, pneumonitis is one of the major side effects, and we have to be careful about this side effect. So conclusion of this OSIFACT study was overall response rate was around 76.2%, disease control rate was around 94.1%, and PFS is better with osimertinib than with the conventional EGFR TK, irrespective of the PDL1 status. But definitely the higher the PDL1, the PFS was lesser in those patients who had PDL1 of more than 50%. TTF was around 19.1 months. The median time for the start of treatment to the onset of adverse effect is around 56 days. This is again one more very important thing to remember. So, when can you expect venous thromboembolism? When can you expect pneumonitis? It is around 2 months time when you can expect pneumonitis. Pneumonitis of all grades occurred in 69 patients, grade 3 or higher in 24 patients, and fatal pneumonitis occurred in around 4 patients. So the conclusion was PFS after first line osimertinib treatment in real world practice was favorable. The discontinuation rate due to adverse effects was around 18.8%, especially pneumonitis requires further investigation. So the third real world data, probably I will just go to the conclusion of this data. Because of the lack of time, I will not take much of this thing. So the study, this is the third real world data. The study provides real world insight into the use of first line osimertinib in the patients with advanced EGFR mutated non-small cell lung cancer based on the first line data cutoff analysis of the US subpopulation. This was this actually the third real world data is actually it is a very well conducted. It's still going on. This data was presented at the interim analysis, and majority of the data in the interim analysis was from US population. There is also a big Asian cohort which is being analyzed, and a European cohort which is being analyzed, which probably in 2013 the full real world, the full analysis of this real world data collection will come out. The interim analysis of this real world real world time for next treatment and death, and real world time to treatment discontinuation results support the effectiveness of osimertinib in real world population. Long term outcome will be evaluated in the final analysis. This third also basically tells that the progression free survival was much better with the osimertinib arm, and it was around 20 months. So all three data of the real world suggest that it is coinciding with the FLORA data. And a few things which I learned with this real world three data analysis is, one is we need to be worried. We need to know about the pneumonitis and the venous thromboembolism as the side effects of osimertinib. So whenever these patients you put the patients on osimertinib, you need to look out for these symptoms. And third is, it is reflecting the FLORA data. So definitely it is a very good drug, and still, I mean, this confirms that it should be the first line treatment whenever you are getting EGFR positive patients. Thank you very much for patient listening.